It's not straightforward. And I think that that's probably the misconception is that there's a one size fits all with these itchy skin cases. And that's really not the case.
Hey, VetFolio Voice listeners, so glad you're here. Thank you for joining me. This episode is sponsored by Elanco and features Dr. Joya Griffin, who joined me to talk about a topic that we find ourselves revisiting quite a bit, and for good reason: itchy skin and atopic dermatitis. And these cases can be challenging. I mean, sure, we will sometimes see the straightforward itchy patient who has fleas and nothing else, but let's be honest, that's the exception, not the rule. Diagnosing and managing itchy pets it's not one size fits all. Fortunately, our understanding and the tools we have for managing these patients have evolved so much over the last several years. Dr. Griffin and I were talking about how it really wasn't that long ago that we had steroids. That was really the only option we had. And now we have this incredible arsenal of anti-itch medications, now including Zenrelia or lunocitinib, to help us fight against itchy and uncomfortable dogs. In this conversation, we get into the importance of getting to a definitive diagnosis and some of the pitfalls we can run into along the way. We talked about what to look for when taking a history in patients who have chronic or recurrent skin disease, specific physical exam findings, and diagnostics that can give us those extra clues as to what's going on with these patients. We also spent some time talking about diet trials and whether or not to challenge these patients once the itch is under control, with all signs pointing back to this kind of overarching benefit of working towards this definitive diagnosis so we can create an effective treatment plan for our patients. It's a great conversation. Dr. Griffin offered a lot of insight into effective management for these patients. Let me introduce her and we'll go ahead and get into it. Dr. Joya Griffin is a 2006 graduate from the Cornell University College of Veterinary Medicine. Following an internship in Chicago, she returned to Cornell for her residency in dermatology, later serving as a clinical instructor specializing in bacterial, fungal, and immune-mediated skin diseases. In 2010, Dr. Griffin became a diplomate of the American College of Veterinary Dermatology and joined the Animal Dermatology Group. In addition to her clinical work and her role mentoring residents and students, she also stars in the Nat Geo Wild television series Pop Goes the Vet with Dr. Joya, which highlights the complex dermatological cases she manages in practice. Outside of the clinic, Dr. Griffin resides in Ohio with her husband, a veterinary internal medicine specialist, their 3 children, and their pets, including her kitten Donut and 2 dogs, Guri and Magic. All right, let's go ahead and jump in.
In the age of Dr. Google and conflicting influencer advice, it's important to follow the evidence. That's why the NAVC publishes free veterinary journals for every member of the veterinary healthcare team. Subscribe to Today's Veterinary Practice and Today's Veterinary Nurse for evidence-based clinical insights. Or check out Today's Veterinary Business for practice management guidance and deep dives on the latest industry trends. Visit navc.com and hit the Publications tab to learn more and subscribe today.
I'm super excited to be joined by Dr. Joya Griffin, and we were sitting here just doing our sound check, making sure our microphones were working correctly. And Joya, you just casually threw in there like, oh, I saw a polar bear yesterday. And like, if there has ever been an argument for like specializing or something, I feel like that's it. And then you also just as casually, you were like, this is not the first polar bear that I've treated. And I feel like that would be a really interesting topic for a podcast.
I know. It's so interesting. I think I love that about being a vet. You know, we get to see some cool things and I learn something new every day because I don't know a lot about all of the zoo species. And, you know, so it's really cool to kind of put my thinking cap on and think about derm in a different way. But it is my second polar bear that I've been able to treat. So I think that's really cool. And maybe that's a point that these polar bears have itchy skin disease, or maybe it's something else. We're going to find out.
Yes, I've joked around many times about saying, I swear we have the monopoly on itchy skin here in the Southeast. But if polar bears are getting itchy skin, like, I don't know if my argument holds water.
There's probably more to it.
Probably. And talking about being lifelong learners and continuing to grow and learn as veterinarians and veterinary professionals, I'm right there with you. That's one of my favorite parts of being a vet. And the topic we're covering today is itchy skin. And this is one of these that, we talk about it a lot from all kinds of different angles, but there's always more to learn about it because as we're learning right here, even polar bears get itchy skin. It's never really straightforward.
And I think that keeps things fresh for me, but also sometimes a diagnostic challenge, definitely a treatment challenge for a lot of these cases, especially because they're sent to me on referral. So they've already been probably worked up and treated in a certain way, and maybe that wasn't successful. And so we have to kind of go back to the beginning and go through our basics and figure out, have we missed things? Have we ruled out all the things that we should? And then do we have a true diagnosis for this itchy pet? And then what are we going to do to treat it and manage it best?
Yeah, I think that's something that I've really learned probably the hard way in treating itchy skin is the importance of kind of getting to a diagnosis, at least as close as we can with the resources that we have. So, when you have these patients that refer to you that have in all likelihood failed kind of the easy button management strategies, how do you go back to the beginning? What's your approach in those cases?
So say it's, a chronic itchy dog. And first things that I do is really sit down and go through a thorough history. I think the derm history is probably one of the most useful tools that we have as clinicians to really think about how did it start? Was this itch that preceded the lesions, or were the lesions the first thing that the pet parent noticed? Because that's going to really set you on two different paths. So say it's a itch first patient, then I need to rule out the other things that can cause itching outside of atopic dermatitis. So, we have to make sure that we have them on good ectoparasite control. Have we ruled out scabies? The potential for flea allergy dermatitis, that can be sometimes a touchy subject with our pet parents. Because I think when you insinuate that a pet may have an ectoparasite or a critter on it, then the pet parents sometimes are like, oh no, my house is clean. Or there's sometimes some objections to doing consistent flea control as well. So I always try to make sure that they're on a good, consistent flea control program, because I just don't want to miss something. And then I, want to explore as well if they've done a novel protein diet trial or a hydrolyzed diet, especially in those non-seasonally pruritic dogs and cats. We have to rule that out. Diet trials are hard. I acknowledge that, really challenging, but really important to do. And then, of course, you can also have cases of contact dermatitis and some of the rare bird type itchy skin diseases like cutaneous lymphoma, which sometimes can present as pruritus. So there are other things that we do have to rule out, and making sure that we're not missing some of those things before we diagnose the pet with atopic dermatitis.
That makes a lot of sense of really diving deep into that history. God forbid we miss something simple like flea prevention and saying, this is fleas. And I agree with you. I've also had those touchy conversations, and, I tend to tell people, I'm like, we're in Florida. Our fleas are made of titanium. They don't die. And so we really this isn't you. Die.
And the other thing too is, I just try to remove any judgment from it. When we have this whole flea discussion, I really put it on myself. I say, I don't want to miss this. I don't want to move forward with some of these advanced diagnostics or spend a lot of money searching for something else when it might be a simple fix. And so we just try to clean everything up as we can. And, the other thing too is a lot of these dogs that have reactions, or even cats for that matter, reactions to pollen allergens, they are also often reactive to fleas. And so it's just a good practice to make sure that we're keeping them safe and keeping them free from flea exposure as much as we can by getting them on a consistent flea control. And I typically will use an isoxazolazine for that, because it's also going to be good for mites and just have a really nice comprehensive treatment for them.
Absolutely. Yeah. Let's do the things that are, I don't want to say easy, but maybe a little more simple. And then, before we start going down this road of trying to get to a different diagnosis that might take, like you said, a little more money, a little more testing, more time, and sometimes more frustration.
Yeah. And what's also kind of interesting too is that sometimes things happen down the road. And I just want to give like a little short example of a case I saw yesterday, actually. Little foo-foo dog. The dad calls him a Pika Chihuahua because it's a tri-mixy dog and it's so cute. The dog has a long history of atopic dermatitis, recurrent infection. In the past, we've diagnosed her with a methicillin resistant staph, and we've been able to control the secondary infections. The dog has been doing really well, really, really well. And then this fall, over the last couple months into the winter, the dog started having really intense pruritus that was no longer controlled by, I think this patient actually has been on Zenrelia and doing really well. And the dog just all of a sudden unraveled, and this is a case where, okay, we may have already had this diagnosis. Maybe we've already ruled out food allergy. Like we're pretty confident it's atopy. And then now something's gone bad. The dog is no longer in control. What's gone wrong? And so we get it in, and the dog has a pattern that's consistent with scabies. And it's got
Really?
alopecia on the ear margins, crusting, severe pruritus, no longer in good control. The family vet had stacked on another anti-itch medication, and it still was very, very itchy. And I'm like, this is, clearly you need to bring the patient in. We need to see it and see what we're missing here. And it turned out that the dog had scabies. So on skin scrape, found eggs, scabala, which is the scabies mite poop, and got it on treatment. So it turned out that they had just sort of gotten lax with their flea control, and the dog goes to a groomer. And that probably was where it contracted scabies. The dad said it was shortly after it had been into the groomer. And so it was just one of those cases where you're like, sometimes things get messy. Sometimes you have to go back and treat what may seem like obvious things, but you could potentially not see that case in clinic and just continue to prescribe what you've been prescribing. And they could keep telling you it's not doing, doc, it's not getting better. And you really wouldn't know that what the issue is unless you get it back in the clinic and examine it and, see those patterns. And I think it kind of brings up a point of lesion distribution is also important kind of things to note when we're seeing these patients as well.
Sure, sure. Yeah, like you talked about with the alopecia on the ears and the crusting and everything like that. The scabies mites can be hard to track down. Is the poop easier to
Yes.
find, the scabala?
It really just depends. I mean, I
Okay.
think a lot of times it's the history. Yeah. And you do have to scrape, do your superficial scrapes in several areas. I also looked for a penile response in that dog. She didn't have that.
Really?
But the pattern distribution was really key for me. And then the sudden worsening in a dog that had been previously well controlled. And then the timing after the exposure to the groomer, that facility, that kind of those things were sort of like, oh, this something suspicious is here. But the dog had very striking alopecia and scaling to crusting on the ear margins, the elbows, and the tarsi, which the caudal aspect of the hocks. Those kind of thinner haired areas are really common for scabies.
Okay, okay. And I'm curious when we're talking about, kind of getting a history here, when we get that phone call that on a previously well-controlled patient who's now worsening, kind of making that differentiation between, say, a seasonal flare versus just the condition worsening over time, being a progressive condition versus something weird happening, like this
Right.
patient got scabies. Can you give us some tips on like sussing that out, or is it just we just need to see the patient and talk to the owner?
It's a really great question. I think it is very challenging to know, especially over the phone, because
Sure.
with atopic disease, it's chronic. There can be ebbs and flows. There can be seasons where dogs are worse, and we do know that over time it is a progressive disease. In spite of anti-itch therapy, like they still can continue to develop worsening of their symptoms, more recurrent infections. There's a lot of things that can occur over time. And that's where, really focusing in on barrier function control, like trying to restore that skin barrier is key. And then trying to reduce the allergic flare through immunotherapy. Those things are more protective in reducing the allergic flare than just doing an anti-itch medication. So it can be hard over the phone. We all are, answering phone calls every day and the pet's worse. And so you add something in or you prescribe something without seeing the patient. And I think if it's maybe 2 or 3 times of that, they have to be seen in clinic. You
Sure.
can't keep prescribing the same thing over and over again and expecting different results. So I think it is important if they're not improving in a a short period of time to get them back in and just make sure. Maybe it's just bacterial infection. A lot of the anti-itch drugs will not seem effective when there's an additional infection on the skin. So you've got to treat that first. Or maybe they've just developed, fleas or scabies or something that seems simple, but until you see it, it can be missed.
Yeah, yeah. No, that makes a lot of sense to say, it's kind of patient dependent, but if we're not having success, even though we know this patient well and feel like we have a good handle of what's going on, that at some point it comes to we need to lay eyes on them and do some diagnostics.
One of the things that we try to do in our practice that may be useful for my general practitioners is that we do a lot of cytology in clinic, of course, because that helps to guide my treatment, help me determine if there's bacterial or yeast infection present and determine, how I'm going to treat it. But I think also when I'm in there doing those exams, I'm kind of talking through what I'm looking for, why I am doing cytology, and why it's not just sort of a guess. And that's why I need the patient in the present, like in front of me, so that I can best be able to support that pet parent and that patient. So those are some little things that I think I try to do so they can see the value of coming back in if things have kind of gone awry.
Absolutely. Absolutely. One of the things that I feel like can hold us back from really working hard to chase down that diagnosis can be the time that it takes to get to the diagnosis, especially if we have to rule out multiple things, because we can't have an uncomfortable patient while we're going down the road of diagnostics, because then we lose any opportunity we have to treat this patient. So how do you approach controlling, I guess, kind of the balance of controlling itchy skin, controlling pruritus while you're getting to the diagnosis, but also not using these medications as like a Band-Aid to mask what's going on with the patient?
Yeah, I think there's, we have a lot of good tools now at our fingertips that, really expanded the way that we treat these itchy patients. And I'm very grateful for that. I kind of got into this field, or I should say when I was in vet school, we had steroids,
Yes. Yeah. When I got out, that was what we like. And then Apoquel went on like the 2-year back order or whatever it was.
Yeah. And now we have more options. And I think it's really just given us a lot of liberty to, not just treat, but to actually do some good diagnostics while we're controlling pruritus. And so whenever I have an itchy patient that comes in, first and foremost, I do have to control the pruritus. We have to put the fire out as we've been trained. And with the JAK inhibitors like Zenrelia and Apoquel, I mean, those drugs are very effective, fast acting medications. And so you can start a patient on on Zenrelia while you're beginning your diagnostic diet trial. You can definitely do that. And that will keep them comfortable while you're doing your 6 to 8 week diet trial and allow them to have that relief. And there's some evidence that doing an anti-pruritic medication at the beginning of a diet trial can actually shorten the duration of that diet trial because it helps to reduce that inflammation in the beginning and that itch. So I like to start the medication to control the itch, begin the diet trial. And then when I'm about 4 to 6 weeks into that diet trial, then I can stop my anti-itch JAK inhibitor because they are so fast acting, but also have a very short half-life. So within a day or two, completely out of the system where we can start to see, has that diet controlled and abated those clinical signs of the food hypersensitivity, or does the dog start to get itchy again? And then we can, determine if that food's been effective or if it hasn't been.
And thinking of diet trials specifically, of course, the way we're taught is we do the elimination diet and then we challenge the pet with a new food to see if it really was the food. And I think there's been sort of this consensus of we don't always challenge the pet if we have success with that diet trial because they're doing well, thank goodness, and it's usually quite a long road to get there.
So I think for me, I agree with you with the diet trials being really challenging. I think to get the buy-in is hard. And for me, a couple things that I think help. One is to explain that this is really the only way that I can rule out a food hypersensitivity in a non-seasonally itchy dog would be to do this prescription novel protein or hydrolyzed diet. I explain the reasons why I need the prescription diet to make sure that there's no cross-contaminant ingredients. We do spend a little bit of time discussing that and looking over the previous food items that the dog has eaten. And then I select diet that's going to fit with that family, and with the needs of that pet. And then once we're going through the diet trial, the one thing that I try to explain to them is that this is not forever. The diet trial is a prescribed period of time, that it's not forever. Because I think sometimes people are not going to want to do the diet if they think that they're going to have to pay $100 a month for ever. But if it's for 6 to 8 weeks and they're understanding this is a diagnostic test, and that at the end of the diet, we have to re-challenge with the old diet to confirm whether or not it was the food that helped, change of season, the anti-itch medication that I've placed the dog on. Like, we have to know really truly that this improvement was from the food by doing that re-challenge. I think sometimes they understand it as a test, and then they understand it as a, somewhat of a temporary thing, hopefully.
Yeah, absolutely. To increase some buy-in there. When we're using something as a Band-Aid to get the effect that we want, which I think, probably isn't always wrong, especially if we're talking about food or something like that, and we're just not going to challenge that. But certainly with anti-itch medication, like striking that balance between wanting to make sure we get a definitive diagnosis and not use medications or food or whatever it is as a Band-Aid that keeps us from getting our definitive diagnosis, versus when maybe it's okay to say, we have success with this plan, we're just going to stick with it.
I do think, for me as a dermatologist, I do think it's important to try to figure out, is it food, is it not? Because food can be easily fixed if we avoid whatever the offending food item is. If we're feeding an expensive diet that's meant to be a novel protein elimination diet trial, and we're doing an anti-itch medication, and we're just continue that forever, we actually don't know what's helping. And that's okay, I guess. But with atopic disease, if we don't know that we're truly dealing with that, it is progressive. And typically over time, it's not going to be enough. And I think what I see on probably a weekly basis are patients that are coming in and they, one, don't actually know what has helped because they're doing, prescription diet. They're also doing the anti-itch medication, sometimes two at the same time, for months to years, and the dog is still having flares. They're still coming in with breakthrough pruritus or breakthrough secondary infection. And they're just like, I don't really know what has helped. I thought it all helped. And maybe it did in the beginning, but I think a lot of times it's not the food that's helped, but it's the anti-itch medication that was prescribed at the same time the diet trial was started, and the anti-infectives that were given at that same time. We usually do 2, 3, sometimes 4 things when those dogs first come in for treatment for pruritus. And there's nothing wrong with that. But I think it's really important to start to peel back the onion so you can actually know, is it worth keeping them on this prescription food? Do we know it's really food hypersensitivity? Or can we move on and maybe put our finances into immunotherapy or into something that's going to be a better fit and fix for that patient?
That makes sense. That certainly from a financial perspective, to say, we don't want to continue a bunch of things and have our clients pay money unnecessarily for a therapy that this pet really doesn't need. And then we have to think about the medications as well. I have a little mini Schnauzer patient who does great on he has atopic disease. He does great on Apoquel. His white blood cells tank. It just doesn't, I just can't keep him on it. He has now been referred to a dermatologist. We went round and round for quite a long time. But, to think about medications and making sure that whatever we're using in our patients is providing a benefit and is doing what we want it to do.
Yeah, I think usually they do provide benefit, but sometimes we don't know why, because we don't actually know what the what the true underlying cause is. And for me, I guess that's partially why I love dermatology so much, because it is very investigative. You're trying to figure it out. I wish clients understood that a little bit better, that it's not just an easy button diagnosis because their dog is itchy. I know what it is. Like, we really have to rule it out. And sometimes I'm fooled, but because atopy is such a progressive disease, I do really want to know so I can provide the best support for that patient over time, because let's be honest, it's not going to go away. We're instead going to have to manage it. And usually we'll be treating it for the lifehood of this patient. So I want to have the best control over trying to manage the barrier function, trying to reduce the allergic flare, and using food as medicine. Maybe they do need a good supportive diet, but maybe it doesn't have to be as limited as they initially thought when they were trying to rule out a food hypersensitivity. There's lots of things that we can do to restore the barrier function from the inside out. And, I love to be able to create that multimodal plan for those patients.
I'm wondering if there are, talking about getting to a diagnosis. Of course, atopic dermatitis being a diagnosis of exclusion. So no test we're going to run that says this is what we're dealing with. And we've talked about good flea control. We've talked about diet trials and like you said, using food as medicine, ruling out a diet hypersensitivity. What are some of the pitfalls? I know you mentioned cytology, things that you see to patients who come into you with atopic dermatitis that you wish maybe would have happened sooner in the workup process before they were referred, that maybe we should be doing more in primary care?
The diet trial is part of it. I think that that's something that sometimes is missed just because it's challenging and hard to do. It's hard to get that buy-in, like we mentioned. And then definitely the provocative re-challenge. I think for me, that still is something that I'm kind of a stickler about, mostly because I want to know, but also I just don't want that client to be hyper focused on food, because that really changes the whole lifestyle of the family when they're worried about dropping a bit of chicken on the floor and they're investing in this food and thinking that it's controlling the pruritus, but they're still on, maybe Cytopoint and Apoquel at the same time, things like that. So I do think that's something that's really important. And then the other part is, like we were mentioning earlier, getting those patients back in for cytology, like actually doing your physical exam and determining, is there secondary infection we haven't managed well? Do we need to really focus in on some barrier function control? And then sometimes the oddball things, is this an older dog that is now presenting with pruritus or secondary infections that then become itchy? Have we ruled out endocrine disorders like hypothyroidism or even Cushing's disease in the older dog? And sometimes it's allergies. I call it allergies gone bad, where we know that the dog is atopic. Maybe it's a Shih Tzu that had seasonal pruritus, pretty well managed with anti-itch medications. And then as it gets older, you're starting to notice it's in the clinic more often for secondary staph infections. Is that just allergies that have become more severe, or has this dog developed an endocrine disorder or something else? So I think, just being cognizant that there are other things that can mimic allergic disease. And really a lot of it is you're just got to get them back in for an exam and think through the history. If it's an older animal, some baseline lab work, thyroid panel is really important.
Yeah, that's a good reminder. Certainly Cushing's I've seen with the recurrent skin infections as well.
Yeah, really, really challenging.
It is. And I think it would be something that would be easy to write off as this is just progression of the atopic dermatitis, but to say, no, there's probably some other things that we should at least look for and rule out in these patients.
Yeah, because for sure. And, atopic disease is a young dog disease for the most part. These are typically animals less than 3 or 4 years of age. There often is a seasonality, but not always. Sometimes they're year round from the start, but worse in the spring and the summer. And sometimes these dogs will have, if you go back through their history, you'll see that they've had a couple incidences of otitis. Like sometimes that's a key. And then usually their lesions are more ventrally distributed. So the inguinal area, the less haired, glabrous areas like thighs, the feet, the face, on the inside of the penne. So if you start seeing itchy dogs, but their itch is top line dermatitis, that's where I'm like, oh, is this endocrine? Is it, potentially even an adult onset demodicosis? I think we forget about Demodex now with our
right, yeah, with the isoxazolines. We're like, it's not that.
Yes, but there still can be some cases, So I think just not pushing everything into the atopy bucket, I think is important too, especially when it's an allergic dog gone bad, when things are becoming progressive. Really important to get them back in and look for that lesion distribution, do your cytology, consider lab work if it's an older patient.
Yes. And while we're talking about lesion distribution, can we quickly talk about contact dermatitis? Because that was always I always thought of itchy dogs as like a 4-pronged thing of fleas, food, atopic dermatitis, and contact dermatitis. But then it wasn't that recent, but a little while ago, talking to a dermatologist, they said, fleas, food, atopic dermatitis, 3-prong, not necessarily that contact. That's not nearly as common.
I think it should still be on the list, but I think you just have to, again, it goes back to the history, because generally contact dermatitis is going to be in a less haired area, glabrous region, maybe the thighs, the
Okay.
belly, sometimes the nose or the mouth. I think that when I was being trained in school, they talked about plastic bowls as being high on the list for causing dermatitis around the face. I think that's probably pretty rare, but people will often switch to stainless steel or glass bowls to try to avoid that. And the dog's still itchy around the face and muzzle.
Sure.
But I think thinking about the lesion distribution and also what contactants or irritants could have been in contact with the skin. Is there something? I think my clients are often changing their fabric softener, their detergent, those kinds of things. And I always ask them, well, are these areas that your dog is pruritic? Are they areas where it's in contact with certain, chemicals or topicals that you put on the floor? We think through it in a very sort of systematic way because I think people want to blame contact dermatitis a lot more than what it really is occurring. And for me, contact dermatitis is atopic disease a lot of times.
I was gonna say, because you can have like in Florida, I know we have a lot of grass allergies, and so we'll
Yes.
get these dogs that go out and they drag themselves through the grass and have a ball outside, and then they get red on their bellies.
Yes.
And a lot of times these are atopic dogs. So how do we kind of distinguish that? Like, where's the line there between this is an atopic dog versus this is a contact dog who's allergic to the grass?
Well, we know it's sort of the pathogenesis of atopy. We know that there's transdermal absorption of these allergens through the skin. And so it tends to be the thinner haired areas, the belly, the feet. And so that's why these dogs are more affected in those areas and why it's important to try to remove the allergens from those areas and then to also restore the barrier function of the skin on the feet, the belly, and throughout the skin, actually. But with contact dermatitis, usually it's going to be some sort of substance that's creating a reaction on the skin, and it's usually acute, opposed to more chronic. So those are kind of some things that I point out to pet parents. And, it's a lot of times it's a scenario where maybe they were prescribed a particular topical in the ears or maybe even a shampoo, and the dog was doing well and then had an acute worsening. It's sort of a very acute change, lesions that came up very suddenly. And one way to differentiate would be to biopsy and send it out for histopathology because there'll be a pattern that's consistent with contact dermatitis if you truly feel like it is a contact reaction. So a lot of times I prescribe something and very shortly after the dog is much worse, as opposed to, they go out in the grass and they have the irritated feet and belly. Like that's just very contact with the pollen, very common with contact with the pollens. And so we just try to manage that a little bit with topical therapy and reducing the allergic flare with immunotherapy.
Yeah, when you explained the pathogenesis there, it clicked for me. We went, oh, okay, like a reaction on the skin versus this absorption that's creating this overall itch for the patient.
Yeah, the immunologic reaction. Yeah.
Okay, that is really helpful. I also want to go back to what you've mentioned several times about barrier function. I can relate personally to the importance of that. I have keratosis and all of this and have had to go down that road myself. And so when we're talking about formulating a treatment plan for these patients, I mean, certainly putting the fire out to get the itch under control, but what are some of the other things we need to make sure we're keeping in mind when we're formulating a comprehensive treatment plan for these patients?
Yeah. So for me, I kind of have a three-pronged approach. First and foremost, I have to control the pruritus. Like this is what's keeping the patient uncomfortable. It sometimes is reducing the quality of life and that human animal bond between the pet parent and the patient with them chewing and scratching and biting all the time. So that first and foremost is controlling the pruritus. So I'm usually going to be putting them on an anti-itch, anti-inflammatory protocol. And so I really like Zenrelia for that, Apoquel, Cytopoint, even steroids in some of these severe cases, or even Atopica. I think sometimes we forget about Atopica and the other forms of modified cyclosporin for these chronic cases. And we choose, really which anti-itch medication we're going to use based off of the needs of that patient. If there's a lot of inflammation in the skin, a lot of recurrent infections, I love the JAK inhibitors for that, or even modified cyclosporin or Atopica, really good for English bulldogs that have interdigital bullae, if they're getting those recurrent infections on the feet, or they have chronic changes in the skin like lichenification, fibrosis in the ears, stenosis, those dogs, cyclosporin can be a nice saving grace. And then Cytopoint, a lot of times I reserve that for patients that need anti-itch control, but don't have as much inflammation in the skin. Maybe they're not presenting with as many recurrent infections. And of course, in some of the refractory cases, steroids are often used as well, especially for short duration or acute flares. So the goal would be to, control that pruritus. And then secondarily, I try to control and remove all of the complicators. And for me, complicators include secondary infections. So I have to control that and treat that appropriately, which cytology is kind of one of the useful tools that I use for that. And then the good flea control program that's consistent to help to remove any potential for flea exposure and flea allergy reactions. And then thirdly, my goal is going to be to try to reduce the allergic flare as much as possible. And a lot of that's through barrier restoration, restoring the barrier function of the skin, and trying to reduce the allergic flare through desensitization. So that's where if I can intradermal test these dogs and get them on immunotherapy that's specific to their reactions, I will do that to help to prevent worsening of the allergic disease and prevent them from needing to stay on chronic drugs over time, but more so as a comprehensive way to control their atopy as best as I can.
And with barrier function, omega-3s, ceramides, are there any big key things that we don't want to miss when we're thinking about healthy barrier function?
Yes, it's a lot of different ways that we can do it. You can do it through fatty acid supplementation or through our skin supportive diets like Derm Complete, which is high in fatty acids to help to restore the barrier function from the inside out. I love food as medicine. I think that's a really easy way. And people will ask, our pet parents want to know, what should I feed my dog? And if they're trying to create this comprehensive management plan for the atopic patient, I think these supportive diets are really great. And then we can also support the skin from the outside in. I love our topical spot-ons like Atopivet or Dermacin Essential 6 spot-on, very easy, user-friendly, apply weekly down the back. They also have collars that help to restore the lipid layer to the skin. And then bathing. Bathing will help to add moisture back into the skin, also removes the allergens from the skin and reduce overgrowth of bacteria and yeast on the skin. So it's kind of, bathing is, if they can do it, I love it. If they can do it, and then we create, a frequency that's going to fit for that family and the needs of the patient, that will help, especially in the summer months. Frequent bathing, really great to do, and in those patients that suffer from recurrent infections.
Yes, I love that if they can do it. And it's amazing how many pet parents are really willing to bathe their pets frequently. Sometimes I'll see big dogs. I'm going, can you do this twice a week? And they say, yeah, no problem. Like, that's amazing.
I know. And I think what you're saying there, like just having that conversation with the pet parents is key. Asking them, can you bathe your pet? And then seeing what they're willing to do. I had one mom that she was a retiree, somehow ended up with 3 very large breed dogs. And I think her husband came back with 3 dogs one day. Literally. And one of them needed some TLC, lots of bathing. And she installed a grooming style bath in her garage so that the dog could walk up into the tub. She was completely on board, willing to do it. I have other families, if they can't get the dog in the tub, they go to the groomer weekly or every other week. Like, they're really invested in their babies. And I think just trying to have that conversation and be open to kind of meet in the middle. If they can't bathe, we have lots of amazing topicals, mousses, sprays, wipes that work great. Big fan of the mousse, as you can bathe once, apply mousse on Wednesday, Friday of that week, and then Monday, Wednesday, Friday of the following week. And they found some good evidence with the Duxo products that can be effective in reducing bacterial infections on the skin. So really helpful tools that we have and lots of options. I think it's very overwhelming when we see new products come to market. Like, how do I choose? What do I use? I know that's always kind of overwhelming. We get decision fatigue.
We do, but oh my goodness, like what a good problem to have because like you said, years ago it was steroids, steroids, or steroids, and that was what we had, or and maybe chlorhexidine and BPO shampoo.
Exactly. And we had very poor flea control.
Yes,
And we
yeah.
have some great, great options to help these patients. I was thrilled when Zenrelia came to market, I guess almost a year and a half ago, because I see the worst of the worst. And I see patients that have failed everything and they need support, and having another option at our fingertips to control itch and inflammation is really great. And I think that that's another thing that we haven't really touched on, but atopic disease is an inflammatory condition. And so we have to not just treat the symptoms of the inflammation. Controlling the itch is great, but controlling that inflammation in the skin helps to prevent worsening of the disease, progression of that worsening skin barrier function. So having these anti-inflammatory medications like Zenrelia can really be useful in reducing that inflammation and that kind of snowball effect that happens with atopic patients.
I love that you brought up Zenrelia again. A big question that comes to a lot of practitioners' minds is what do we do with the box warning on Zenrelia? And there's been some changes to it recently. What do we do with the box warning for Zenrelia, and what are some of the recent changes?
Yeah, so for me, I talk to my pet parents about it in the exam room whenever I mention any new medication, but especially with Zenrelia because it has, this little bit of a different label. So I hit it head on. I don't want them to find from the internet or from a friend or the breeder. I want them to hear it from me and for me to be able to explain it and for them to understand the why of the box warning. When it came out, they had recommended withdrawal from the medication 1 month to 3 months before vaccination and up to 1 month afterwards, because during the original vaccine response studies, they took 8 unvaccinated 10-month-old puppies and put them on 3 times the Zenrelia dose. These dogs were vaccinated, and some of the dogs had poor titer response at 88 days to the distemper and rabies vaccine. Unfortunately, these dogs also came down with coccidiosis. So they had intestinal parasites, which has also been shown to reduce the immune response. So the label came out because of that. And there was some dogs that actually contracted hepatitis. They have since then found that this was naturally occurring disease, adenovirus, and not related to the vaccination. But initially, there was a label that stated may cause fatal vaccine induced disease. And that has been removed because now we know that those dogs that were euthanized with hepatitis actually had naturally occurring disease and it was not vaccine induced. So, which was suspected, but now we had proof and that was removed from the label. So now the label is just concerning reduced response to vaccines due to the immune modulatory or immunosuppressive effects that Zenrelia could have. But again, the study was, these dogs were at 3 times the dose. So how do I handle this? For my patients, I only use Zenrelia in adult fully vaccinated dogs. And we discuss the vaccine withdrawal 1 to 3 months prior to vaccination and then 1 month after. And then if I need, I will discuss this with their family vet and we'll decide what's going to be best for that patient, which will put them on some other anti-itch medication during that withdrawal time. But there's a lot of evidence that you could vaccinate if you felt comfortable. A patient that needs to be on Zenrelia, if you felt comfortable doing that. During the US field trials and European field trials, dogs were allowed to be vaccinated during those studies. And there was an Apoquel and Zenrelia head-to-head study as well, and dogs were allowed to be vaccinated as normal.
I love it. That sounds really similar to how I handle it with clients. And surprisingly, I don't feel like I've encountered much pushback from people when talking about it, including the vaccine withdrawal. When we do take those patients off, I haven't had a lot of people that seem very concerned with that. They've been very compliant and haven't been too worried about it.
Yeah, I think they understand it. And I think in human medicine, there's similar vaccine recommendations with the JAK inhibitors. And I think we're just maybe vet medicine is like, slow to the game on that because that's kind of how those immune modulatory drugs are handled in human medicine. So not a huge deal, I think, because it's different. It seems scary. It seems unfamiliar, but I have not had too many issues with it and patients have done really well. And I have Seen really great success in my patients with Zenrelia and being able to control that itch and inflammation and reduce the incidence of secondary infections has really been nice.
Absolutely. Absolutely. I'm sure you have more experience with it than I do, but in my limited experience, I would agree. I've seen really good responses with it. And Dr. Griffin, I want to thank you so much. This has been so informative. I mean, it's amazing to me every time we talk about atopic dermatitis and itchy pets. It's covered from so many different angles, and there's always something more to learn. There's always something that will improve our ability to manage these patients every time we have the conversation. So thank you so much for joining me and for all of the amazing information. Any final thoughts you want to share?
Oh, no, you're so welcome. I think as this disease continues, or as our understanding of it continues to evolve, we'll be able to hopefully, and have more targeted treatment options based off of specific patients' needs. And it's not kind of just when do I use, how do I choose, and that we're going to be able to really have more targeted care. And I'm really excited about that.
Dr. Griffin, thank you so much for just the wonderful conversation. So insightful. I really appreciate it. I also want to say a big thank you to Elanco for making this episode possible. And of course, thank you to all of you out there for tuning in. For more episodes like this, click on the education tab on the VetFolio website or find us wherever you get your podcasts. If you enjoyed this episode, can you please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this episode and find other great content that we're continuously trying to put out there. As always, I want to hear your input on this talk. I want to hear ideas that you want to hear from us in the future. So reach out to me at dvm@vetfolio.com, or we can connect on Facebook at Dr. Cassie DVM, or Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.